Hello everyone, I'm Sung-Hae from Shizuoka, Japan. I'm going to present the premature babies with coarctation of aorta. In the case of severe coarctation, primary surgical repair is usually performed early in life. However, the surgery is sometimes necessary even in prematurity due to systemic hypoperfusion or heart failure caused by atrial mismatch. As shown in this table, there is higher risk of complications and mortality with surgery and balloon dilation in premature infants. And there have been few reports of stenting in extremely low birth weight infants with coarctation. We experienced 3 cases of stenting in extremely low birth weight infants with coarctation in recent 4 years. Our strategy included implantation of a coronary stent, followed by redilation and surgical arch repair with stent removal. The first case was born at 33 weeks of gestation and 902 grams. As shown in these movies, LV dysfunction developed due to atrial mismatch. The aortic isthmus was around 1 millimeter. The first intervention was performed at 10 days of life. We placed a marking tie at 20 millimeter tip of a 3 French short sheath and inserted it into the left common carotid artery by echo-guided puncture. We put a purse string suture around the puncture site for hemostasis after removal of the sheath. We struggled to cross the isthmus by the guide wire. However, the combination of a steerable microcatheter and the hydrophilic wire crossed the isthmus but advanced to the RV through the PDA by chance. At this point, the wire was exchanged into a 1/4 stiff wire and dilated the isthmus to PDA with a 2 millimeter balloon. Next, we changed the wire course into isthmus to descending aorta, and then a coronary bare metal stent 3.5 millimeter in diameter and 8 millimeter in length was positioned jailing the PDA. Subsequently, the gradient increased again, and we decided to do re-intervention at 2 months of age, 2 kilo, with 5 millimeter ballooning through 3 French sheath in the femoral artery. And then, arch repair, including stent removal, was performed at 5 months of age, 3.5 kilo. The second case was born at 29 weeks of gestation and weighing 723 grams. He was transferred to a hospital at 28 days of life due to progression of heart failure and showed DCM-like LV dysfunction. The isthmus was less than 1 millimeter, and first intervention was performed the next day. We applied the same system as the previous case. This time, a 3 French sheath was inserted in the right common carotid artery. Combination of the same steerable microcatheter and the hydrophilic wire crossed the isthmus and reached the descending aorta more quickly. Next, the wire changed into a stiff wire and pre-dilated using a 2 millimeter balloon. Then, a coronary stent was placed, also jailing the PDA in the same way in perfect position. The PDA of both cases completely closed soon after stenting. Gradually, his ventricular function improved as he grew up, and we underwent the redilation of the stent at the age of 124, 2.1 kilo, and arch repair including stent removal at 8 months, 4.7 kilo. We went into red zone with the third case. The patient got more premature and smaller, and he was born at 27 days of gestation, weighing 386 grams. He was managed in the other NICU far away from a hospital until 31 days of life. And in this particular case, the left ventricle was hypertrophied against severe coarctation with closed ductus. This chart illustrates the clinical course at the prior hospital until 31 days. PDA closed after administering indomethacin, and subsequently, prominent ventricular thickening occurred. And the isthmus dilated exactly the same way as before. It took 49 minutes from sheath insertion until removal. We found the stent just in place. We are very happy to get him back in our NICU. However, 20 minutes after the return, he became completely pulseless due to permanent left ventricular hypertrophy and loss of inside cavity. He never recovered despite volume infusion and resuscitation. We obtained autopsy imaging, CT and MRI. They showed permanent LV hypertrophy and the stent was still just in place without aortic injury. This chart illustrates the summary of the 3 cases. The patients got more premature, 35 down to 31 weeks of gestation, 914 down to 504 grams. Conversely, we dramatically reduced skin-to-skin procedure time, so I must admit there is a significant learning curve. There seems to be no technical difference in case 3, but progressive myocardial hypertrophy was exacerbated after releasing the afterload by stenting. Regarding the procedure, the biggest challenge was crossing the tortuous pathway from carotid artery to isthmus. Our solution is the combination of a tip-turning microcatheter and a hydrophilic wire. We applied coronary bare metal stent implantation as the initial palliation. Because it will maintain the isthmus longer than the plain ballooning until the second and the third intervention along with the patient's growth. The one thing we regret about the third case is that the initial stent size was too big for this patient, and gradual and serial dilations were more appropriate than full expansion at the first step. Anyway, such condition requires as early intervention as possible before LV dysfunction develops. 감사합니다.